If you've ever stared at a therapeutics question and second-guessed whether you picked the right drug for the right patient, this video is going to fix that. Therapeutics by system is one of the biggest content areas on the evaluating exam under the current blueprint, and the candidates who score well aren't memorizing every drug in existence. They're thinking in frameworks. Stick around, because in the next few minutes I'm going to show you exactly how to do that. Here's the honest truth. Most people study therapeutics by making giant drug lists, and then the question gives them a 60-year-old with diabetes, heart failure, and chronic kidney disease, and suddenly the obvious drug is completely contraindicated. The exam tests clinical reasoning, not rote recall. So before we dive into any specific system, burn this into your brain. Every therapeutics answer lives at the intersection of the right drug, the right patient, and the right clinical context. Once you start filtering your knowledge that way, the questions get a lot easier. Before you choose any drug on a therapeutics question, run it through 3 filters. First is the drug indicated. Sounds obvious, but it eliminates a lot of distractors. Second, what rules it out? A beta blocker is great for hypertension, unless there's severe asthma in the chart. Third, does it fit this specific patient? Renal impairment changes dosing and drug choice. Pregnancy flips the whole list. Age matters. These 3 filters apply whether you're in cardiovascular, respiratory, endocrine, or any other system. Practice applying them and you'll stop second-guessing yourself. Cardiovascular is dense, so let's anchor a few patterns. In heart failure with reduced ejection fraction, think of the core pillars: renin-angiotensin blockade, a beta blocker, and a mineralocorticoid receptor antagonist. In a patient with hypertension and chronic kidney disease, an ACE inhibitor, or ARB, is the preferred starting point because of the renoprotective effect. For atrial fibrillation, the exam loves to test whether you address both rate control and anticoagulation for stroke prevention. Don't get so focused on the rhythm that you forget the clot risk. These are recurring themes. Know the why behind each choice, not just the name. Respiratory questions almost always hinge on correctly distinguishing asthma from COPD and then selecting the right drug class. For asthma, the long-term controller is an inhaled corticosteroid. That's the foundation. For COPD, the foundation shifts to long-acting bronchodilators, LABAs and LAMAs. The common mistake I see? Candidates confuse the two because both involve inhalers. Watch for comorbidities. A patient with COPD who also has heart failure might be on a beta blocker, and that's acceptable for COPD, but beta blockers are a red flag if the diagnosis is asthma. Details like that are exactly what the exam tests. Diabetes pharmacotherapy has evolved a lot, and the exam reflects that. Metformin is still the conventional first step in type 2 diabetes, but once you're adding a second agent, the choice is driven by the patient's profile. Does the patient have established cardiovascular disease? An SGLT2 inhibitor or a GLP-1 receptor agonist may be preferred because of proven cardiovascular and renal outcome benefits. Is hypoglycemia a concern? That shapes whether you avoid sulfonylureas. Type 1 diabetes is a separate world. It's insulin-dependent, full stop. Practice mapping patient profiles to drug add-ons, and you'll ace these questions. Let's apply everything. A 68-year-old woman has type 2 diabetes, an eGFR of 35, and a recent heart attack. She's on metformin and aspirin. What do you add? Run the filters. She needs cardiovascular protection after her MI. That points toward a GLP-1 agonist or SGLT2 inhibitor. But at an eGFR of 35, some SGLT2 inhibitors have reduced efficacy and require checking prescribing thresholds. A GLP-1 receptor agonist is generally safer across that renal range and has strong cardiovascular evidence. This is how you work through a complex therapeutics case, not by guessing, but by layering your filters one at a time. Let me save you some marks right now. The biggest mistake candidates make is falling in love with a drug name they recognize and not checking the patient details. The exam will always put the contraindications somewhere in the stem. You just have to read carefully. Renal and hepatic function clues are almost always there for a reason. Pregnancy is another trap. Drugs that are perfectly fine outside pregnancy can be dangerous in it, and the exam exploits that. And always ask yourself, is there a well-established first-line option here? If yes, that's usually the answer, unless something in the stem rules it out. Here's a practical study tip. Stop making linear drug lists and start building a therapeutics map. For each major condition, think heart failure, hypertension, asthma, COPD, diabetes, depression. Create a one-page summary that includes first-line therapy, common alternatives, and the contraindications that switch you off the first line. Then add a column for special populations. That structure mirrors how the exam actually asks questions. And critically, pair every study session with practice questions. Reading passively won't build the clinical reasoning you need. Active retrieval will. All right, you now have a real framework for tackling therapeutics by system. The 3-filter method, system-specific patterns, a worked example, and a study map strategy. If you want to go even deeper, we have a detailed study guide and question bank on our Etsy shop, AI Universe CA. The link is in the description and pinned in the comments. It covers high-yield conditions across every system, with practice questions built specifically for the evaluating exam. Drop any questions you have in the comments. I read every one and I'll answer them. And if you want to be the first to know when new videos drop, hit subscribe. Good luck with your prep. You've got this. If this helped, check out these other PEBCBuddy videos to keep your prep going.